bags are biting me and things are overcoming. How many of you just cringe when you hear someone walking through the room and tell you they're dizzy? It's like everyone, sometimes myself included. I have a few exposures here, none of which apply to this talk, so we can skip right over that. So what I want to talk to you about today is what is our current state of balance and vestibular evaluation following concussion. I come from an objective vestibular laboratory, so I'll be giving you some objective data, but also what can you do on your bedside level or even on the sideline. And then what can we do about dizziness and balance after concussion? And we know that dizziness is quite common, and it is noted in some research studies that if you have someone who is dizzy at their initial presentation, that they may be associated with a prolonged recovery. And just some new data is coming out showing that up to 81% demonstrate abnormalities in either abnormal gait stability, so vestibular or ocular reflex function, or tandem gait to balance testing. Children and adolescents who present with these sorts of vestibular findings at their initial presentation will take up to 3 times longer to get back to school and up to 4 times longer to get back to play. So these aren't insignificant symptoms that the patient is presenting with, and we do have some options to get them feeling better faster. So as far as what happens in a concussion with the vestibular system, and there's really not a good answer to that. There's a whole lot of things that could go wrong with the vestibular system. Looking at the peripheral system, there can be direct injury to hand organs. Benign proximal positional vertigo is commonly presents after injury. 11% of adults after post-traumatic head injury. Labyrinthine concussion, or microhemorrhaging into the inner ear space, cortisoras, hydrops, all kinds of things happening on the peripheral system. More commonly when we think about concussion, we're talking more central injury. This can be diffuse axonal injury, post-concussion headache or migraine phenotype, as well as cervicogenic vertigo. So we'll focus a little bit more on the more central findings, as that's where most of our abnormalities pop up in our younger kids, and particularly those for concussion and TBI. One thing though I think is important to remember is that it's not just one system in isolation. The vestibular system doesn't have a specific home in the cortex. It's everywhere. And so what we rely on with our balance system and our vestibular system is integration from across various sensory modalities. What we know about the vestibular system is that we need very precise dynamic flexibility and timing in order to maintain appropriate interpretation of vestibular information. Damage to the peripheral system will alter the input that you're getting into the cortex, but damage to the central pathways alter spatial computation. So your timing, your phase become out of sync. So information coming from the vestibular system, the visual system, your somatosensory systems don't always line up quite correctly. And this is where many of the symptoms come along. I talk a lot about visual vestibular mismatch in my patients, and these are patients who get quite busy with the visual environment, walking through a grocery store, looking at busy visual carpet, that sort of thing. And in these patients, what they're describing is a sensory disagreement. So the information coming in to perceive motion is coming from your vision, your proprioceptive system, and your vestibular system. And when those aren't read correctly due to their abnormality in the spectrum or a timing difference, they become out of sync, and one sense organ becomes more dominant. In this case, typically it becomes the visual system, and we become very reliant on visual information. Overdependence on the visual system can lead to prolonged imbalanced dizziness, nausea, and instability. And this is a mismatch or disgust of information that can give you prolonged symptoms. I typically use a bit of a triad when looking at the concussion patient. In this case, in looking at post-concussion in children and adolescents, I focus mostly on balance testing, ocular motor evaluation, and gait stabilization testing. And these are all tests that you can use in your office. You don't need fancy equipment or infrared recording to do them. I'm just very fortunate I have that, so I use it. Well, what is ocular motor testing? This is one I think we've all talked about. You'll all do this bedside, and you know how to do these evaluations. But ocular motor evaluations are quite important. 30% of athletes will report vision problems during the first week post-concussion. This is something as simple as my vision feels a little blurry, I'm having difficulty reading, or getting dizzy or headache. They also note it's difficult for them to read. They're not able to concentrate on reading materials. And of course, these are symptoms that are very symptomatic and can significantly impact academic performance. There are quite a few different tests that you can do particularly by looking for gaze development diagrams, which I don't find quite often in patients after a few days post-injury, but you can still sometimes see it. Optokinetic nystagmus, smooth pursuit, saccades, as well as convergence and accommodation. The important piece is that because over 50% of our neural tracts are impacting the ocular motor system, this can provide significant information about the health of the brain and can give you a lot of information on how stable that patient is moving forward through your rehabilitation. So these are just a couple of examples of what I see under infrared. This is a 22-year-old male. He was injured just a couple of days before we gathered this data. This is a smooth pursuit. And we can see it's really just an inability to track appropriately. And if you look here, these are, for example, saccades. You can see he's fixating forward, but his fixation is not quite good. So he demonstrates a bit of jitter around the point, possibly a little diplopia, multiple dots, but obviously somewhat of a sliding jerk embedded in there. And that's quite common to see after the first couple of days. Most commonly, looking at our data sets, smooth pursuit demonstrates significantly reduced pain in about 35% of patients. That's followed closely by saccade testing, which demonstrates significantly abnormal latency in about half of those, and an abnormal accuracy in about half of those showing abnormalities. So this isn't something that is unusual. You should see some ocular abnormality following injury. Now, these data are not necessarily patients showing up a day or two after injury. These are patients who are symptomatic. So this could be patients who is a few days out versus about a month out, but they're still showing symptoms. Let's switch over and talk a little bit about imbalance. Balance problems are one of the more commonly reported symptoms. We can thank our colleagues in physical therapy who've done a lot of work looking at the balance measures following concussion. What we do find in our balance patients is that they do demonstrate an increased reliance on visual input. As we talked about earlier, relying heavily on the visual system in order to navigate their environment, even though that system may not be the most accurate for their task. We do also find that they have a poor use of vestibular input. So these aren't patients who necessarily have vestibular lesions, but they're not using that information correctly or accurately in order to maintain balance. They often will demonstrate abnormal sway patterns, and they're lower composite score on formalized testing, but this may not be outside normal limits, which I think is probably the more frustrating part, in that when you are testing patients using standardized metrics, you know they're probably not normal, but unfortunately they're normal. There is a bit of a timeline. We're looking at balance testing and the different types of tests that we have. I'll talk a little bit about some of these measures in the next few slides. But looking through the literature and looking at the recovery time to get these tests back to normal limits, if you're looking at something like the balance scale scoring system, which is a subjective sign measure, this can resolve back into normal limits hours to days after injury. Some of our standard sensor organization tests or center pressure gravity tests will normalize within a few days after injury. It's only when we start looking at dynamic tests that we can see the long-term effects of even a simple concussion. So static balance tends to resolve within 3 to 5 days. More dynamic balance can take over a month. Unfortunately, I get to be a bearer of bad news for several of our kids who look really great on neurocognitive and neurology evals, but they can't pass dynamic balance testing. And unfortunately, I can't send them back out in the field if they can't do that. So the take home here is, as you increase the task difficulty, you're going to have an increased recovery duration. So it's not overly complicated to stand with your eyes closed if you're standing still in an office. And if you're having to stand with your eyes closed on an unstable platform, that can become a little more difficult. And so by increasing the difficulty in those patients, that can help understand further in the recovery process. This becomes especially important for a high-performing athlete, not even high-performing, just any sort of athlete, before you get them back on the field. May not be as important for someone who's not quite as active, to touch these more involved dynamic conditions, but it is something to consider and keep in mind when you have somebody who's still telling you they have balance problems, even though they're a couple of months after a concussion. So these are some terrible videos. Many of you are not well balanced. But the downstairs scoring system, this is a test which does that's looking at the ability to stand in three separate conditions. So standing feet together, standing on one foot, and then in a tandem gait. And this is something that you can do with fairly moderate reliability. Unfortunately, it's generally done fairly subjectively. You do need a stopwatch, and if you're going to do a full vest, you need a piece of foam for them to stand on. There are some standard values available for both the full vest and the modified vest, which is just standing on a firm surface, which is generally done on the sidelines. These metrics do depend on the sport, so there is some evidence that there are certain athletes in certain sports that are going to perform better in this than others, and so that may be something to keep in mind. And the data suggests that if there's a greater than 5-point change on the best score, total score, then that's an indication that they have a balance trouble and should be pulled out. Unfortunately, that doesn't work so well in the pediatric group. These are some of our data from my youth athlete study, looking at 106 mostly preseason football players, most of them male. And these are the data from the tandem and single leg stances broken down by age 11 through 13. I didn't give you the double leg stance because they're all normal in that stance, which is good. They can all stand on 2 feet. But when looking here at the tandem leg stance, for the most part, they don't do too poorly. They have a few errors. So, falling out of position, unable to maintain that stance. And if you look at the percent reaching a maximum of 10 points per condition, you can get 3 to 10% of them who will reach that maximum in that condition alone. Switching over to single leg stance is fairly similar, although they do similar errors, so those might be in the future. They're not so great at this task. And if you look at the 11 and 12-year-olds in particular, 30 to 40% of them will reach the maximum number of errors in doing this condition. And so we have to think about, is the modified vest a good tool for maybe our older kids, our college athletes? Maybe. So there's a lot of data on that. But in children, it's maybe not the best metric. There are a lot of errors in normal functioning kids, simply because there's a lot of poor balance in these kids. The vestibular reflexes are not mature. There are some pros. It's easy to use. There's a lot of data on this task. But there is a significant variability with age and a high number of kids who can reach the maximum number of errors allowed within these subtypes. So this is what we've gone to in most of our pre-season testing. We're using the time tandem gait from the step 3. This is pretty easy to do. You set up a line of tape, and you have the participant walk all the way down, all the way back in a tandem gait. I'm not good at this task, so I would not be passing. So you walk as quick as you can, you step off the line, turn around, and come back. At baseline, you do this 4 times. You can cut off 10 seconds doing this once you get some practice. If you step off the line, if you fall off the line, that's an error. You can't count that one. But what you're looking for is how quickly can they do this task. And the adult literature has reported that 14 seconds or less is the typical amount of time it takes to walk that line there and back. In kids and adolescents, though, add about 10 seconds to that. So there is quite a bit more variability when looking at children and what they can do in this sense. And again, these are some more data looking at became engaged in that same group of kids, just quite a few more of them this time. This was, again, pre-season, pre-football concussion baseline testing data. And again, looking at kids from 9 to 13. What you see here when looking at the youngest kids that we tested, the 9 to 10-year-olds, the 95th percentile cutoff is about 28 seconds. So it does take them a while to get all the way down to the end of that line and back, but they can do it. And what's nice about this tool is that there's no maximum score. So they can be as slow as they need to and do this task, and know that it's not going to cut out during this test. You do see a significant age effect, and so this is something you have to do every year in order to get a good baseline, because you do see a significant decline in time as the kids get older. Generally, I would bet by the time you get to 16, 17, they start to get closer and closer to those normal limits, but in these younger kids and early adolescents, it's going to take much some time to do this task. So that 14 seconds that you see on the stat tree is only for adults. You can't use that metric for the kids. There is a high variability again with age, and unfortunately I don't know the significant change, and so right now we're using any change from baseline. But until we get some more data on concussion, then we'll be able to get that data better established as far as when to pull someone out. Important also, make sure you do this barefoot. That's the easiest condition to control, and if you can control the surface that you're walking on. There are some differences between concrete and turf and grass, so be careful on that when using this task. I'll talk a little bit about some of the objective data that I can collect in my lab. All of my graphs, the data will be set up the same, so regardless of the score, they'll be broken down into acute and prolonged groups. The acute patients are just divided arbitrarily to about 30 days post-injury or less. Those prolonged greater than 30 days. And then, of course, whatever the score I'm putting on the y-axis. Anything in red is abnormal, so that's always a good marker for looking to see how many of our patients are falling into that abnormal range. For those who aren't familiar, most balance lab use some sort of sensory organization test, which is a metric to look at the effects of vision, vestibular, and medicine information on balance. And it allows us to break down that balance into those components and look for where they have difficulty. When looking at static balance, standing on a force plate and looking at the amount of play, not many of our kids do that badly, even when they're symptomatic, coming in very acutely after concussion. This is pretty similar to maybe what you're seeing in Romberg testing, when you have them stand still, eyes closed, eyes open, not seeing too terribly much play on those measures. And that's what we see here. We only get about 28% of my acutes as abnormal in this data set, which is a lot of equipment for not a lot of results. What I have been doing, and what you can do pretty easily even under Romberg, is to add a dynamic component. We're adding just a head shake. You can do this with any sort of dual task paradigm, because I know my patients typically have some overriding cognitive impairments. I tend to not use the cognitive overlay, but use the vestibular input. And that's just a simple head shake. So just shaking the head back and forth while they're trying to maintain balance. Now what you don't see on here is that the floor that she's standing on is unstable, and she has her eyes closed. So this is in theory a more representative of vestibular input, and so I'm looking at can she maintain balance when she has to alter her balance and posture based on the information coming from her ears. And when you do that, you're going to collect quite a bit more abnormality in both acute and prolonged patients who are complaining of issues related to balance. So if you can add a dynamic task to any of your balance assessments, whether it's a Romberg in your office or a dynamic gait task, or if you have access to a vestibular lab or postography lab, this can really impact the amount of time that you're going to need to get that kid back to play, but also can help you understand what the underlying pathology is and what's contributing to that sense of imbalance. One thing I do want to talk about as I'm a vestibular audiologist is the vestibulo-ocular reflex, and that's what I spend most of my life looking at. The goal of your VOR is to make sure your best vision by moving the eye contrary to the head. So this is your gaze stability mechanism. Lowering your gaze, keeping your vision stable when you move. It's a very quick 3-round arc. so involving the semicircular canal, scrotal organs, central processing, and motor output of the eyes. So unfortunately, none of these DLR measures work in concussion. They're all normal, which is great in a lot of ways. But unfortunately, our patients are still having problems with DOR. They're still dizzy. Their eyes are blurry when they walk. They're still having a lot of trouble in visually provoking environments, which are related to abnormalities of the DOR. But their caloric testing, rotational chair testing, head rest testing, in general, is all normal. Never 100% of the time, but I haven't seen it yet. But what we do know is that a lot of them have problems with gait stability. This does require that the DLR is functioning appropriately, but as far as we can tell, we don't have any problems with the quick reflexes required of the DLR. But what we do want to know is how functionally impacted was the DLR by the concussion. And this could be an impact in the cortex, really anywhere throughout the DLR. And then what can we do to look at the functional impact of this vestibular pathology? Finally, I think one of the most important pieces is looking at the effects of gait stability impairment on rehabilitation, which is, I think, one of the reasons you guys are here. Abnormalities of gait stabilization involve whole host of things. So, of course, feeling dizzy or nauseous. They may tell you that they have a lot of blurry vision, but also some other symptoms that I tend to pull out are difficulty when they're working on a computer or when they're taking notes in class. They may have difficulty playing video games. Anywhere where there's a fixed point that they're keeping their eyes, that they're doing a lot of head turning around that point, can trigger a gait stability abnormality. You may find that these are patients who get dizzy when they're in busy places, so grocery store syndrome, that we've had quite a bit of literature on. And then they might be patients who have an increased motion intolerance. Maybe kids who weren't sick before, but now they have to sit in the front seat. And so motion intolerance is another key indicator that there could be something abnormal in their gait stability. Something you can do really easily. There are a lot of apps now that you can download a quick spelling chart if you don't have one in your office. I have one taped to a couple of doors all over my office. And there's some ways you can do this on a computer as well. But essentially what you're doing is you're looking at the ability to maintain visual focus when the head is moving. So to do that, you get a baseline. What's your vision look like when you're sitting staring at the sound chart? And that doesn't change when you start moving your head. You have to move your head fairly quickly. You have to get into the frequency only at the VOR, but it's a quick vector, so about 2 hertz, back and forth, can you still read at the same level? If you can't, that would suggest that your gait stability is off. And this is really quick to do in your office. It takes all of about 2 seconds, and your patients will hate you for it. These are the data that they hate taking patients off the read. Alright, so again, these are data looking at acute and prolonged patients, and I have a computer system, so I can divide it into rightward head movements and leftward head movements, just to be a little more fancy. And what I find is that about half of my patients, when they come in symptomatic, have abnormalities in gait stability. So what does that mean? Are they going to get dizzy when they go to school? Absolutely. Are they going to feel terrible if they get in the car? Probably. So there are a lot of these symptoms that you can isolate in an objective way and try to understand where some of their underlying abnormalities are coming from. This is something I would highly encourage adding into your battery if you don't have someone who's doing this test for you, either in the physical therapy lab or the vestibular lab. It's very quick and very easy to do and quite sensitive to pulling out some of these abnormalities. So adding dynamic information is always going to improve your ability to detect injury. Alright, so you have patients who have abnormal motor function, they have poor balance, poor gait stability, they're dizzy, they're motion intolerant. These are like when they gotta go to rehab, right? Everyone goes to rehab in my lab. Unfortunately, a lot of these abnormalities to resolve over time. Most of the data that I get on ocular motor dysfunction tends to resolve within the first couple of weeks. Balance, they do pretty well. They start to recover, and if I'm looking at them dynamically, maybe about a month or so out, they can pass my test. also have an array with gait stability. They're going to hate it for that first week, but after a few weeks of recovery, that gait stability metric comes back into normal. But they may still be motion intolerant, they may still be nauseous, they may still be dizzy. Not having them or not having any of these metrics doesn't mean that they don't need some sort of intervention. And quite honestly, we have to be honest about our metrics, and that they are likely going to miss a few patients here and there, probably a lot of patients, due to the normative limits that we have to use to encompass our test paradigms. But there are quite a few things that you can do in order to get your patients to the right person. Physical therapy, occupational therapists, they've been doing a lot of work in the realm of concussion management for quite some time and have a lot of tools in helping patients to recover from these symptoms. There are also therapists who specialize in ocular motor function. If you can find one, make good friends with them because they are fantastic at getting patients better. Also important to emphasize the effects of exercise and conditioning and getting patients moving again. Generally don't recommend these patients to get on the treadmill or the elliptical machine if that's a nice VO stimulus, like get them on the bike, and that can help to help rehab them as well. It's very, very important though that it's not just any therapist. It has to be someone who knows concussion, who knows vestibular symptoms, and preferably has worked with kids. Because unfortunately not all therapists have exposure to all those different types of patients. And so you want to find some colleagues who can help you manage these patients by looking at them specifically in terms of what they can offer your concussion athletes, but things that may come through your door as well. Does it work? That's always the question. How many of you have patients who go through your vestibular rehab and like they work? It's like everyone. That seems working. That's the goal. Unfortunately, other than just 3 weeks, it's limited, but it is promising. There's not a lot of controlled information. There's not a lot of randomization in this literature base. Overall, there is evidence that vestibular rehab is more effective than just less graduated exertion. There was a fairly recent study looking at randomization figure in children and young adults, and finding that if you added vestibular rehabilitation, manual therapy, some more sensory motor retraining, you can get them back to start by 8 weeks of post-injury. As compared to those just on a less graduated exertion, they're only getting back to play in about 7% of cases. So there is some strong evidence that getting them moving, getting these reflexes functioning appropriately can really improve their return to play. So generally, vestibular rehab will decrease symptoms over time, generally not at first. The first few times they'll crazy the whole time they're there. But that's okay, you have to get them moving. The brain only rewires for these reflexes if it's in motion, if the systems are stimulated. And there are no significant negative effects. So if you are able to get them in with a good therapist, they should be able to get them back on track for recovery sooner. Often what they'll be working on is adaptation of the vestibular ocular reflex. So their tasks are usually involving a lot of head motion. You'll see if you walk by the lab, they got stuff on the wall and the patients are just turning their head back and forth. And that's going to help adapt the vestibular ocular reflex. They're also working on symptom habituation. They can also help you work on ocular motor function, although sometimes a specific therapist related to ocular motor therapy is quite helpful there. And of course, we're going to be looking at gait and balance. The nice thing about physical therapy is that they are all functionally based, and so they're going to be putting them through tasks that are appropriate for their everyday life activities and can really emphasize all of those tasks that perhaps we don't get at in the objective lab and that perhaps you don't have room for in your evaluation area. But all of this rehabilitation is individualized, and that can give you the most effective outcomes there. There are quite a few comorbidities though that I think you can take home from this have to be addressed as well. So it's not only vestibular rehab for everyone, but any sort of cognitive or behavioral issues that need to be addressed any sort of visual perception dysfunction, so having an evaluation by someone through your ophthalmology department and looking at the visual system as a sense organ is always helpful. Metabolic dysfunction, which we haven't talked about much today, but any sort of underlying unmanaged metabolic dysfunction, so someone who has diabetes may be more prone for dizziness anyways, and so managing some of those other underlying symptoms would be helpful, and of course autonomic dysfunction. Dizziness related to postural stance doesn't really get better with vestibular rehab, and so looking for other conditions that can contribute to that can help. But in general, we want to get these addressed as well. Vestibular pathology, based on typically central integration issues, can lead to significantly prolonged recovery. These are kids and young adults who are going to have difficulty with integrating information from the vestibular system into maintaining their sense of orientation and their sense of balance and stance. If you're doing some quick and easy testing and you don't have access to lab control with the trifecta of ocular motor testing, balance testing, and gait stability, you're probably doing 2 of the 3, I would assume. But adding in gait stability testing can be helpful in identifying those kids who are still at risk. And rehabilitation is the best option we have for them as far as vestibular rehabilitation and balance dysfunction, and it works. We see this in our kids and getting them into rehabilitation fairly early, within maybe about a month or so, if they are having prolonged symptoms. But these are specialists who understand concussion, they know neurologic disease, and they know how to work with our kids. So based on that, I've given you a whole host of references if you feel like delving into the matter, and with that I will end.